forms of adverse childhood experiences and their impact on health, both for children and adults. In collaboration with Dr. Vincent Felitti at the Kaiser Permanente in San Diego, they did a groundbreaking study published in the American Journal of Preventive Medicine in 1998 and really started, I would say, a movement that continues to this day. It's probably one of the most important population health movements that exists. He will tell us much more about that. Rob continues to work as a CDC senior scientific consultant. Most of what he does right now is this: traveling around the country, speaking, consulting, spreading the word about this important topic. So we are indeed fortunate to have him here today, and I'd ask you to please join me in welcoming him to Maine Medical Center.
Thank you, Mike. Can everybody hear me okay?
Yes.
Good. Okay. I have a little less than an hour here to immerse you in what I've learned in the last 20, 25 years doing this work. So some people say it's kind of like drinking out of a fire hose hearing this presentation. So I just want you to sit back and observe what you can and take in what you can. There's not going to be a test or a quiz afterwards. I'm going to talk about the implications of adverse childhood experiences for the healthcare system, but I think more importantly, I believe in this idea of self-healing communities, and I see them emerging around the country as I travel. If you look at this sort of engineering design, I didn't know how else to do this, all the gears and the belt between the gears. The biggest gear in the system is people who've been affected by the stress and trauma of adverse childhood experiences. The majority of people in any community, and probably the majority of people in this room, have experienced adverse childhood experiences or one or more forms of traumatic stress. And so as a population health person, I believe that most importantly, we need to get this information that I'm going to talk about today out to everyone as a public health approach and a grassroots approach. And as a healthcare provider or person in the healthcare system, I believe that you're one of the central gears in this idea of the self-healing community. You are at the nexus of all these systems, and you see the kids and the families, and you have the opportunity to ask them about this information in their own lives and to understand how it affects their behavior and their social problems and their life trajectories towards disease and disability. And my hope is that as part of that nexus, that you will begin to interact more with some of these other systems where adverse childhood experiences lead people into the justice system and the welfare system, and the education system plays an important role in self-healing communities. This is a cover art that I've been using for some years. It was somewhere around 1990 where the AMA's newspaper had this as the cover art. And it was the first time that the AMA tried to teach physicians that domestic violence was a healthcare issue. And I show you this, it's kind of hard to look at, but you see a child who's maybe kindergarten age, somewhere around there, and two parents. And this child is in fight or flight, so highly aroused, and in that biologic state of fight or flight. And it took me a few years of showing this to begin and talking about this issue of compassion and trauma-informed care for people who have been traumatized, to look at the parents and not be upset with the parents. Let's just think about that for a second. Why are they having difficulty raising this child and having a relationship with each other that is not angry, violent, or emotionally dysregulated, and therefore stressing their child? And people don't understand that potentially this kind of stress for their children may have lasting long-term biologic effects and affect their life trajectory. So I believe that it's really important to take an intergenerational approach to traumatic stress and adverse childhood experiences and work with these parents so they can do better. You know, you can't make it all go away, but you can make it better. And generation after generation, the amount of traumatic stress that's transmitted person to person will go down, and we'll see less adversity and fewer of the consequences that I'm going to talk about this morning. That's my belief, and that's why I'm getting on airplanes and flying around and traveling and talking about this. A little bit about the biology of adversity, or the biology of stress. As you all know, when we're stressed, we have fight or flight, and that involves the release of adrenaline and cortisol. But if that release, that stress response, that biochemistry of stress is unpredictable or severe, it leads to vulnerability. And primarily because cortisol in high doses or repeated doses is toxic to developing brain cells. It makes it difficult for them to reach out and make functional networks. And in really high doses in animal studies, it's neurocidal. It kills nerve cells in high doses. If it's predictable or moderate, it leads to resilience. And I use resilience in the sense that for those of us who don't get biologically overwhelmed by stress, we can hit a speed bump of stress and then come down. And then we're ready for the next one, and we can adjust as the stress comes and not stay in that high biologic stress mode. The things that determine the difference between vulnerability and resilience are, how many times does this happen while we're developing as children? Does it happen many, many times or once or twice? And is it intense, the nature of the stress? And is it chronic? Does it go on day after day, week after week, month after month, and year after year? And I'm going to talk about, very briefly, about the biology of how this works in terms of the effects of the stress response on neurodevelopment, and this new field called epigenetics that I'm still a rookie at. I'm learning about, so I'm going to try. There are people here, forgive me, people are really good at this. I'm going to go through a little bit of epigenetics this morning. This is from the Harvard Center on the Developing Child, and it shows a hippocampal cell here up on top, a normal one. It's really colorful and vibrant, and it's ready to reach out and make great networks. The one below is one that's been exposed to a lot of stress, and I told you about the effect of prolonged or repeated stress on nerve cells, probably because of the effect of the cortisol on the cells. It damages the cell. And under an electron microscope, you see a little piece of this cell where it's got many places where it's ready to branch out and to begin to develop healthy neural networks. In a damaged neuron, there's about half of the ability to make connections with adjacent neurons. And just very briefly, this is an adult brain. The neuroscience of this is expanding really rapidly with advanced scanning techniques and doing case control studies of people exposed to childhood stress compared to those who have not. But just very briefly, here is the amygdala. It's our early warning firing system. If you go to like fireworks and an aerial bomb goes off, everybody does that. It's automatic, and it's not under conscious cortical control. In children exposed to a lot of stress, compared to those who are not exposed to a lot of stress, on average, the volume of the amygdala is greater. So people who are exposed to chaotic, stressful, or violent experiences during childhood actually have this adaptive response. And that's part of being trauma-informed. I don't know how many of you are trauma-informed, but it's an adaptive. Our neurons learn and our DNA learns from our experience and adjusts our development to be ready for the environments that we grow up in. So being hypervigilant and ready to respond to stress is actually an adaptive response. Here is the hippocampus in adults with PTSD who were exposed to abuse during childhood. On average, the volume of the hippocampus is lower. That means more difficulty with memory and the other things that functions of the hippocampus, including emotional regulation. And the corpus callosum. There's up to a 17% reduction in the volume of neurons in the corpus callosum among people who are abused as children compared to those who are not, which means that big highway of neurons that connects the front of the brain with the back of the brain and the ability of information to move from side to side is actually impaired because of the lower number of neurons in that system. And there's many other findings that are coming out from the neuroscientists looking at the biology of stress. And the genome, this is new stuff that's really, I think, maybe at the heart of why childhood stress or adverse childhood experiences have so many varied and powerful effects throughout the life course. One of them is that the telomeres, which are like the ends of shoelaces on our shoes, help hold the DNA, the chromosomes together tightly so they don't fray and get disorganized. Telomere health appears to be affected by exposure to stress and violence. So the integrity of the DNA itself can be affected by these kind of exposures. And in one longitudinal study of twins, the researchers found that the twin exposed to violence had shorter telomeres than the one who was not. But the good news in that study was if the child was removed from that type of environment by age 5, that the telomeres expanded. So there's the possibility for our DNA to heal if we reduce the level of exposure early in childhood. Now, here's my attempt to describe epigenetics. So bear with me. We have our chromosomes with a tightly packed DNA, and we've seen a telomere. And you see this in this graphic from the National Institute on Alcohol and Alcohol Abuse, showing the unwinding of the DNA and expanding out. The DNA is wrapped around proteins to keep it organized. Imagine if you went fishing without a pole and without a reel, you'd have a real mess, right? So our DNA is really long. It needs to be organized so it can unfold and be ready to be presented to the cell. When you get to this level, where there are 8 of those, it's called histones. And if you look at these little orange cylinders, that is where something called methylation occurs, DNA methylation, where there is one of those cylinders, it blocks that next stage of unfolding of the DNA, which is the unfolding to the point where you actually have the gene code exposed to the cell, so the cell can take that code and do whatever function or operation that gene tells you to do. So DNA methylation is really important in which genes are presented to the cell, ready to be opened up and read, and which are not. That's my basic understanding of epigenetics. And that's a fluid process. It's constantly be turning on and off, depending upon our experiences. When we eat, it gets turned on and off. During the day, these things are being turned on and off. And importantly, there's new research showing that adverse childhood experiences influence gene expression and can determine the methylation patterns of the genome, and therefore the biology of the functioning of the cells. And I'm asking the question now, as we develop self-healing communities, if we have these adverse childhood experiences and methylation patterns that lead down the pathways to disease and addiction and mental illness and the problems I'm going to tell you about, that perhaps as we do better and interact differently with our patients and our families and our children, that may be reversible, because people can get better. And I wonder if in the future we're going to see those methylation patterns that we see in conditions of toxic stress, that those are reversible. So the memory of our experiences literally gets stored in our bodies. And our DNA learns. It learns from our experience and prepares us to be ready for the environments that we live in. Now I'm going to move to this idea of adverse childhood experiences and the model that Dr. Felitti and I used to think about this. We're both internists. And when I met him, I was at the CDC, and he was running the Department of Preventive Medicine in San Diego, and we were both really frustrated. And we sat and talked, and we said, our culture and internists, adult medicine, we come in after there are already problems in place. And that's okay. We want to fix problems that are there. We're not going to stop doing that. But we wait until there are social, emotional, and cognitive impairments, risk behaviors, disease, disability, and social problems. And a lot of times it works. We can help people with those kind of problems, and a lot of times we can't. and it's really expensive. And so we wanted to get down to the very bottom and say, what is the primary origin, the pathways by which some people have these risk behaviors and social problems and some do not? So we came up with this idea of looking at adverse childhood experiences. And we used a whole life model from conception to death, with time going up this way. So I want you to imagine time from conception, or now even preconception, flowing up through the pyramid this way. And we've learned that ACEs disrupt neurodevelopment, leading to these impairments that lead to risk behaviors, disease, disability, social problems, and early death. And now we're also learning from people that are studying how the genome works about the epigenetic mechanisms by which these things occur. And I'm going to re-emphasize the idea that as people move up, that they have these experiences and become adults, that there's an intergenerational cycle of transmission that we need to disrupt. It's person-to-person transmission vertically. It's a vertical transmission of stress from one generation to the next. So I'm going to tell you a little bit of the background about the ACE study. Dr. Folletti and I enrolled more than 17,000 people from the Kaiser Health Plan in San Diego into this study to look at the health and social effects of ACEs throughout their life course. It was done in a primary care setting. So these people were coming in for preventive care. These were people who were not coming in because they were sick. They're a well-educated group of people. Only 6% don't have a high school diploma. Most have been to college or graduated from college. Primarily middle-class population and upper middle class, which is what San Diego is, and predominantly Caucasian. And what I like to do to have you think about this cohort of 17,000 people is, if you wanted to develop a study and get 17,000 people, it would be hard to get 17,000 healthier people with these kind of demographic characteristics, who also at the same time have some of the best health care in the world. So this is, in a way, this is sort of what we think of as a best case scenario for how much adversity is there and the impact that it has on people's lives. So if you scratch the surface of the demographics, you see that adversity doesn't know socioeconomic boundaries, and the biology of adversity doesn't change depending upon where the population is or the demographic characteristics. So the first thing we found, which was profoundly disturbing to me, is I didn't know, I was studying cardiovascular disease. I'd never looked at these kind of things, child abuse and neglect and domestic violence. We found how common these types of adversities were. There were 10 of them in these 17,000 people. The first group we called household dysfunction. 27% grew up with substance abuse in their home, more than 1 in 4 with the relational stress of parental separation or divorce. 17% were raised by a mentally ill caregiver. 13% had witnessed their mothers being physically abused, which we called having a battered mother. And 6% had criminal behavior in their home, such that someone in their home was incarcerated where they were growing up. So they were exposed to the behaviors, and also there's the loss of relationship involved with incarceration. 11% had been emotionally abused, 28% had been physically abused, and 1 in 5 had been sexually abused growing up. And neglect, which is not getting the kind of experience that you need for your networks to develop and function the way we'd like them to function. 15% had been emotionally neglected, and 10% had been physically neglected. So we were sort of new in this field, and it had not really, this array of adversity had not been put together in one study before. And what we found is that these kind of experiences don't occur in isolation. Mostly they tend to come in clusters and groups. Where there's one, there's usually multiple others. So if you were one of the people on this little table, if you were one of those people that told us that you grew up with alcohol or substance abuse in your home, your chance of having one of those other 9, there were 10 adversities, one of those other 9 as a percent is 81%. 8 out of 10 of you would have one of the others. And if you go to the far right, almost 60% of you would have 4 of those. So the first stressor is the alcohol or substance abuse, then you have 4 or more. So 60% of you would have 5 or more childhood stressors in that constellation of stressors in your life. So there's this sort of packaging. And statistically, we couldn't separate all these interactions between adversities apart, so we did something really simple. We just added those 10 up and created what we call the Adverse Childhood Experiences Score. Each experience counted 1 point, an integer count, so it was from 0 to 10. We found that only 1 in 3 people in the Kaiser Health Plan had none of those childhood experiences, which means that 2/3 had 1 or more. And here you see the scores. And I now think of that score as a measure of the cumulative dose of stress during childhood, the biology of stress during childhood. 26% had 1, and even when you go to 4 or more, 16% had 4 or more adverse childhood experiences. So as I show you these graphics, I think of this score as the cumulative stress dose and how that impacts people across the lifespan. Let's start with adolescent health. Here across the bottom is the ACE score going from 0 to 5 or more. And the height of these red bars is the percentage of people that told us they started using what we called street drugs by age 14. It's less than 1% for an ACE score of 0, and you see this cumulative dose response effect as the stress goes up. The percentage of those who initiated drug use during their youth goes up. At 5 or more, this is 10%. So there's a 10-fold increase in the risk of starting drug use as a youth for those with an ACE score of 5 compared to 0, with major increases in between. Here is teen pregnancy. Women who reported at least having 1 teen pregnancy during those years goes from 10% to almost 60%. And you see throughout all these graphs this dose response. I had never seen anything like this before. I had tortured data sets over and over to try to get dose response and publish the data because dose response gets published. Over and over again, you'll see in these graphics this dose response. And I think what we did is we hit on it's like a Rosetta Stone of how stress influences human biology and neurodevelopment and cellular function. Mental health and substance abuse. Here, across the bottom, is the ACE score going up. The pink bars are for women. Let's just look at that. The probability of a lifetime history of major depression goes from 15% to 60% for women with ACE score of 4 or more. Here is the prevalence of attempted suicide. Attempted suicide was the most non-random behavior that we found in all of the behaviors that we studied based upon learning about adverse childhood experience. There is a 20 to 40-fold increase in the risk of attempted suicide as the score goes up from 0 to 4 or more, 5 or 6 or 7 or 8 or more. 20 to 40-fold increase in the risk of suicide. Here's addiction. Looks very much like the early initiation of drug use. This is people who reported they've ever been addicted to what we called at that time street drugs. A 10-fold increase across the scale from 0 to 5 or more adversities. Here's alcoholism. Am I going too fast? These all look the same, don't they? I could change the headings on them and you wouldn't know the difference. And I can tell you when at the CDC, when I started showing these bar graphs to colleagues, they didn't believe it. They said, there's something wrong with your program. You created a loop in your program to analyze this data that creates bar graphs like this. So here's the probability of being an alcoholic goes up 6-fold across the range here. And also we were interested in relationships. The probability as an adult of growing up and marrying an alcoholic or a drug addict or someone who is a perpetrator of violence looks much like that set of bars on the right. So it affects relationships, who we tend to become intimate with as we grow up. So I'm going to give you a quick summary here of what we published. ACEs have a strong influence on this list of common health and social problems: adolescent and reproductive health, smoking, obesity, drug use, alcohol abuse, sexual behaviors, mental health, the risk of being a victim of violence as an adult, the stability of relationships, and we even looked at how people function in the workforce and their ability or inability to do their jobs or show up on the jobs or to get along at work while they're at work. And ACEs are a pathway to preventable diseases. Here we have liver disease. I don't know if you went to a hepatologist, any hepatologists here? You know, what's the primary cause of liver disease if you go to all the way down to the origins? Wouldn't say, well, it's the biology of stress that leads to intravenous drug abuse and exposure to the viruses and to alcoholism and to the sexual behaviors wherein the viruses are transmitted. But this is part of the pathway to liver disease. And here's coronary disease. On the far right, an ACE score of 3 or more, there's a doubling of the risk of coronary disease. Only about a third of that risk in our data, as we looked at it with multivariate statistics, only about a third of the relationship between childhood stressors and coronary disease in an adult is explained by what we think of as the risk factors for cardiovascular disease. So there's these other pathways that probably involve the biology of stress and the functioning of the genome that lead down this pathway to coronary disease. So here's a list of what we published. ACEs more than double and sometimes triple or quadruple the risks of some of these leading causes of death: heart disease, chronic lung disease, stroke, diabetes, and cancer, especially lung cancer, liver disease, suicide, injuries, HIV and STDs, and autoimmune diseases like lupus and rheumatoid arthritis or even thyroiditis. The immune system, people are now showing that the immune system tends to be upregulated in people who are exposed to a lot of stress during childhood. And we've followed this cohort of people, 17,000 people over time, when we got their death certificates a few years ago and saw who had died and what they died from. People with ACE scores of 6 or more compared to those of ACE score of 0 on average died 20 years younger. So that's the tip of the ACE pyramid, which is premature mortality. So I'm going to go, I don't know if you can read this, but I want to sort of summarize and then move on to maybe what this means at this medical center and your practices. ACEs cause predictable patterns of brain development, traits, and behaviors. That includes slowed language and reading, lateralization, which is the movement from side to side in the cortex of information, diminished IQ, poor decision-making skills, problems with memory, attention problems, ADD and ADHD, or things that just look like ADD and ADHD because of the hyperarousal and the way the brain functions under conditions of stress, aggressive behavior, social isolation among peers, poor understanding of social cues leading to conflict, the early use or abuse of alcohol, tobacco, illicit or prescription drugs, special education, school failure, dropping out, suspension, expulsion, delinquency, and entry into what people call the prison pipeline. If you look at these behaviors where there's alcohol and drug abuse and mental illness, is a pathway into contact with the justice system. And then as adults, this process tends to lead to adults who have low-wage jobs, who are unemployed, on public assistance, who are incarcerated, with chronic health problems, mental health and substance abuse problems, and difficulty with their parenting and maintaining relationships. And that leads, again, to this idea of the cycle of the intergenerational risk. And we can intervene along all these steps and at least make it better. We're not going to make it go away in our generation, but our job is to slow this down during childhood and adolescence, and to work with the adults who are parenting or the caregivers or people who are working with children so that they don't transmit or transmit less of that intergenerational stress, so when they grow up and be parents, the cycle winds down. So let's go to healthcare. Part of this study and following this cohort over time, we had access to all of these amazing Kaiser records, their administrative database, and we had every single prescription that those 17,000 people got over 7 years. So here is, over time, over 7 years, the rates of prescription for antidepressant medications. And we talk in epidemiology about person years. One person followed a year is a person year, so we smash all the time of follow-up together to create what we call person years. So this graph is per 100 person years of time followed over 7 years. Here's ACE score 0 to 5 or more. At 5 or more, it's 100 prescription per 100 person years, which is on average 1 prescription for antidepressants per year per person, for people with an ACE score of 0. And we estimate that half of the prescriptions for antidepressants are related back to the adverse childhood experiences decades earlier that are manifesting in adult life. That's one of those. And we talked last night over dinner, this is unpublished, but there's a very powerful relationship between the ACE score and prescription for opiate medications. I know you have a big problem with opiates here. The Kaiser formulary has 15 classes of drugs in it, and here's the list. I'm not going to read it out to you. You can take a quick glance at it. These are all the classes of drugs. There's 15 of them. So what we did next is we said, what about polypharmacy, or getting prescriptions for multiple classes of drugs? This graphic is those who are prescribed 8 or more different classes of drugs out of those 15 in the formulary over 7 years. That's the height of these bars, and here's the ACE score. And this is, we decided to do this for younger adults. This is for people who are 18 to 44 years at the time of entry into the study. So these are for younger adults. It's about 12% here, and it increases to the point where 1 in 4 people with an ACE score 5 or more were prescribed over a 7-year period 8 or more different classes of drugs out of the Kaiser formulary. Then we started to look at the review of systems that was in the chart. And I want to tell you this story. Dr. Folletti and I, when we started to see this data, said, this is an incredible burden on the healthcare system. We went to the medical records group at the Kaiser Health Plan, and it's such a big system that it's like a huge warehouse full of charts. And we said, we want to pull all the charts for those 17,000 people and weigh them. And the people in the record were freaked out, said, we're not pulling 17,000 records for all these people for you, but we wanted to get the charts and weigh them to see how much they weighed. So unexplained symptoms. Here is the percentage of people that had 5 or more symptoms in their review of systems without a corresponding diagnosis or explanation for that symptom. So these are 5 or more unexplained symptoms as the score goes up. And here again, it gets as high as 1 in 4 people with high ACE scores have 5 or more unexplained symptoms, and frequently in multiple different organ systems. And those symptoms, as you know, and as you would expect, generate a tremendous amount of service utilization. This is the percentage of people who had 10 or more doctor office visits in the last year. And here, this is the number of unexplained symptoms, not the ACE score. So ACEs create unexplained symptoms, which in turn generate high number of doctor office visits as measured by 10 or more in a year. So being trauma-informed. How many people here consider themselves trauma-informed? I've heard of the term trauma-informed. Okay. Trauma-informed. I became trauma-informed about 6 years ago when I went to a work group in Wisconsin. I went to the trauma-informed work group, and I sat there and I said, what are you talking about trauma-informed and trauma-informed care? He said, is that a protocol? I didn't know what it was. Trauma-informed is a mental frame shift. When you understand the biology of stress and how it affects the way people function, and that functioning is adaptive. It may have negative consequences, but our DNA learns and our brains learn from environment, and we function in a way that works in the environments that we come from, and we do things to cope with, adapt to those kind of things that may have negative consequences, but they work for us. And so it's the mental frame shift in public health and medicine and the schools and in the justice system that I'm seeing that changes the question from what's wrong with you and starting to understand their lives so you understand what happened to them and put their health and social problems in the context of how they were affected developmentally by their experience. And to help them understand that as well so that they can be informed about themselves and not ask themselves what's wrong with me and say, look, here's how I adapted. And this worked for me. So I want to use the example of smoking. Everybody, it's hard to find somebody in this culture that doesn't know that smoking has negative health consequences, right? So people who smoke aren't dumb people. And it's not because they didn't go to health class in middle school and get the pamphlet about smoking, right? So there's a high-grade relationship between smoking in early childhood and adolescence and adult life and adverse childhood experiences. And that is explained by the fact that adversity leads to functioning in the brain where there is depression, a lot of anxiety, and difficulty concentrating. And when we smoke a cigarette, we get nicotine. And nicotine is a powerful antidepressant. It's an anxiolytic drug, and it helps people to concentrate. So the smoking is a functional adaptation to the way the brain develops under conditions of stress. And probably, I believe, the drug abuse and the alcoholism and some of the other behaviors are a way of functioning when you're in that kind of state. So the ACE score, I see it as a history tool that can be used in any kind of setting, whether it's healthcare or the justice system or anywhere else. It's a history tool. It's also a communication tool that allows us to talk comfortably with each other about our experiences. If people assemble their ACE score, they can talk about their score without talking about some of the things they might be uncomfortable talking about that they experienced. So they can talk about their score, and you can talk with your patients about their score without getting into the details of exactly what happened that may be a little bit too uncomfortable, at least at the beginning. And I find after doing these presentations in libraries and other places that people will come up and tell me their score. And then you hear a buzz afterwards, people talking about their scores with each other. So it's a communication tool for us and for people in community to begin to understand each other better. And it's becoming part of a common language as I travel. The number of hands that go up is increasing rapidly when I say, does anybody know what an ACE score is? And it's a gateway to empathy, compassion, and understanding that can improve provider and patient relationships. So here's some ideas about how you might do this. And these were carefully crafted ideas done by public health nurses that spent more than 2 years with their visitations on getting ACE scores and responding to their clients and communicating with them about adverse childhood experiences. So this needs to be framed, and these are some ideas of how you might do this here if you want to do it. Framing the asking of these kind of questions. We now know that childhood experience has a big impact on health throughout our lives. These ACE questions are important for us to work together to improve your health and the health of your family. You can support the next steps in the conversation. For example, people with high ACE scores often have to work harder in many aspects of their lives. How have you managed to do so well? You see the reframe there, the trauma-informed reframe? That's really important. And then you can build from their answer to build their strengths, the fact that they've adapted, and to foster resilience, and how they've been resilient in their lives. Or, I'm sorry these things happened in your childhood. We didn't know back then. The science is new. Now that we know about the power of ACEs, how would you like to use that information to improve the health of your family? And the framing here is a little bit, how would you like to use that? Because the response is important. There's not a protocol. And the people can take their own lives and frame it and begin to tell you how it affected them, and then understanding their needs that you may be able to provide, or find somebody else who can provide that for them. And the Jefferson County Health Department in Washington found this protocol did not increase office visit time or trigger a trauma response in their clients, which is a frequent fear when people get involved in asking these kinds of questions. And simply you can ask, how have these experiences affected you through your life, and just listen. And people who have some kind of basic understanding of what I'm presenting this morning will begin to tell you and understand and put it together for themselves. Because people who've experienced these things don't naturally assemble their life history like this. They need help. What I found is how we grow up was normal for us. When we see it laid out and help each other assemble the history and then see how that affects biology and health and behavior and social problems, people put the pieces together and I see the light go off. Oh, I've had people come up to the podium and say, I have an ACE score of 10. Why didn't somebody tell me this before? Now I get it. Now I understand. And you see the relief. You can almost see the stress reduction. They're very grateful that someone has talked to them about these things that our society has not been comfortable talking about, and helping them assemble sort of the snapshot picture of their lives so that they can change and empower them. I believe it empowers people to change and move forward. And one of the most powerful things that I see is that adults who have children say, I understand my ACEs, I understand how it's affected my life, and now I'm going to do things differently when I go back home. That may be the most powerful part of this whole public education aspect of adverse childhood experiences, the effect that it can have on parenting and family functioning. So here's some reasons to make, I believe, for you to consider, at least, making these kind of histories a routine part of every chart, of every history. Here's the care issues with high-ACE patients, comorbid conditions. I showed you one at a time, but as the ACE score goes up, the number of co-occurring social health problems and behavioral problems goes up dramatically. Multiple somatic symptoms resulting in high levels of testing and referrals to different providers. Frequent visits, high use of emergency room and no-shows, and high pharmacy use and polypharmacy. And you might consider it in your practices or here at the medical center, asking you, who are our high utilizers? And can trauma-informed care for your high utilizers that are having their care driven by the consequences of adversity reduce their costs and make their lives better? It's hard on patients to go from provider to provider and test to test and test over and over again and get all those services and all that care and not have resolution to what they're dealing with. And if you want to think about the predictive value, the yield when you do screening, if you take your higher ACE patients and do the routine screening for the common conditions like depression or anxiety or substance abuse, your yield for time spent will go up dramatically because the percentage of people with those problems is higher. So yield, predictive value, is directly proportional to the percentage of people that have that problem in those groups. And then once you get into screening and you have highest patients, you may want to consider the next time going deeper into these other levels of things that may be hidden at first screenings. So I would think you should consider using the ACE history in combination with enhanced screening and assessments, and to trigger referrals to trauma-informed practitioner in the community if you have that kind of referral system, or to somebody in your team who's good with this. And I want to stop here first. Not everybody's going to be good at this. But there are people in this room who probably like to do this kind of thing, who are good at it as a member of your team that you could refer them to. And then develop systems. And this is a real challenge in healthcare. How do we begin to deliver intergenerational care and merge pediatrics and adolescent health with adult health? Because it's vertically transmitted. How do we do that? Compliance. Why do ACEs reduce compliance? They're associated with cognitive, attentional, and memory problems. They interfere with trust, relational trust, which is a prerequisite for your relationships and adherence with your patients. And they tend to have chaotic lives and relationships that interfere with routines required for ongoing care. And we talked last night about the demands. If there's poverty, you can't pay your electric bill or your gas bill, or you don't have food. What is your priority? And your life is chaotic, and you move frequently, and you don't have a job. It's hard to pull this all together. It may not be highest on your list to follow the instructions of your care provider. So part of this best practices of being trauma-informed is having empathy for your patient's view of disease and their treatment when you understand the fuller context of their lives. Relationship building and reminder strategies. Reduce time between visits. And cognitive supports for tasks that require follow-up. So I believe that addressing the behaviors, social problems, and physiologic risk factors earlier and more aggressively among people who've been exposed to a lot of adversity may prevent or delay the onset of poor physical, mental, and behavioral outcomes and reduce the intergenerational cycle of their transmission. So I'm a prevention guy. I'm into prevention. This pie chart, in the pie, it has multiple health and social problems around the pie. And this was developed by a clever woman from the state of Washington who watched me present this idea of population attributable risks, which is jargon, epidemiologic jargon. She said, Rob, you do a terrible job of explaining. Nobody understands what you're talking about when you talk about population attributable risk. So she developed this for me. Population attributable risk is simply the percentage of a problem that is caused by an exposure that you study. So in this case, it's the percentage of health problems, not the risk for, but the percentage of the health problems caused by adverse childhood experiences using standard public health simple calculations. And what she did, this was at the time that the BP oil well blew up in the Gulf of Mexico and contaminated the ecosystem of the Gulf of Mexico. So she made this pie chart and put an oil slick on the chart to say this is how adverse childhood experiences contaminate the human ecosystem. So the slick represents the percentage of those problems caused by adverse childhood experiences. So if you go around this chart, 54% of depression we estimate is caused by these experiences. Half of disability days, the inability to do your daily functioning, to get up and care for yourself or go to work. Half of domestic violence, almost half of sexual promiscuity and high-risk sexual behaviors. Almost 80% of intravenous drug abuse. 2/3 of life dissatisfaction, people who just feel like, my life, I don't like my life. I'm unhappy with my life. Almost 2/3 of alcoholism, half of drug abuse, almost 60% of suicide attempts, and between 40 and 50% of people reporting hopelessness. And we can put all different things on this pie, on this wheel, and show these numbers. These numbers in the history of public health are unprecedented. Attributable risks of this size only occur in things like smoking and lung disease or asbestos exposure and mesothelioma. We see here 50 to 80% of some of the most difficult health and social problems have their origins in the biology of stress during childhood, which means, so you can look at this and say, that's really scary. I look at this as a prevention and I go, this is the greatest opportunity for prevention of health and social problems that we've ever seen. As we address this and dial down the intergenerational transmission of stress, we have the greatest opportunity ever to make the health of our society improve from one generation to the next. And if we don't, there is some evidence to suggest from surveys that the cycle of intergenerational transmission, at least in the state of Washington from multiple database, it's going up. So I'm going to come back to this idea of self-healing communities. I'm traveling, talking about this. We go around the country training cohorts of people to give presentations like this. Anywhere they're invited, to community centers, to government organizations, to nonprofits, to all different kinds of service providers, so that I believe that as we reach critical mass, and in some places of this country, critical mass has been achieved, where the wheels are starting to turn. And solutions emerge. I'm not here. I can't tell you exactly how to use this information here because systems are different in different places, but people that see this information come up with creative solutions and different ways of trying things that seem to get these gears turning in self-healing communities. So I've left about 5 minutes for questions. I want to thank you for inviting me here this morning and for coming and listening. And I wish you luck in building healing communities here. Thank you.
Thank you, Rob. That was really marvelous. I really appreciated the presentation very much. So here's how this is going to work. We have a few minutes for questions for those of you that have to leave and can't stay for the panel discussion. At 9 o'clock, we're going to break. There's coffee and refreshments outside. Those of you that are staying, you have 5 minutes to come back in. So by 9:05, we're going to start the panel discussion. So do we have any questions to start with for Dr. Handa? Oh, sorry, John.
Wonderful presentation. Thank you very much. I'm actually meeting with our interns tomorrow to talk about this time of year where empathy sags, and I'm fascinated with using this as a way of sort of giving tools to practitioners who are saying, how do we begin to think and help us be better at caring for patients? So it's fascinating that way. The other question I have is more sort of with regards to your research and so forth. One would think that if this epigenetic process has gone on forever, as long as humans have been present, that these negative the negative impact of these adverse, of the ACEs basically, would have sort of bred out some of these things. And rather, it seems like there's an acceleration in what's happening over time, or by your posit is. Can you speculate why that would be? Why? I'm certain that alcoholism and physical abuse and neglect and so forth were rampant in Shakespeare's time, but it's sort of speculating on sort of a historical trend over time.
There are no data on adverse childhood experiences over time. The CDC has built surveillance systems. Now, most states now collect this data in their public health surveys. But in terms of the epigenetics, I think there's now powerful information suggesting that the methylation patterns in DNA that are based upon experience can be stable in meiosis, when the gametes are formed, and therefore that our experiences are transmitted from one generation to the next. And there's, one of the examples I've heard of, there's a woman named Rachel Yehuda who's studied PTSD in the offspring of Holocaust survivors. And they found that the next generation, the grandchildren of Holocaust survivors, had higher rates of PTSD. And over the years, the explanation had been that it's the trauma of hearing about those experiencing and knowing that that awful thing happened, that it was the telling of the stories. But apparently there is an epigenetic marker that skips a generation. And there's other studies now, there's animal studies that show that exposure of a pregnant rat mother to a smell and a noxious stimulus in the lab, when they're not pregnant, that the pups of those animals, after they're born and they're exposed to that smell without the stimulus there, they stress out. And so, in a way, in the evolution of things, if you think about our DNA, our DNA learns, and it teaches us to be ready for what's in our environment. But now we live in a time where those kind of dangers aren't there, and so it's a functional process that has negative consequences in the way that our society expects us to behave and to function, like the drug abuse and substance abuse and other being violent or aggressive under certain circumstances is a functional behavior. But in our society, it tends to be something that's not functional. It's passed on. So it's like I could go on. It makes me ask, like, is DNA alive? And I think it is, because it learns. Yeah.
Well, thank you, Rob. We're going to have to break it off there. 5 minutes for refreshments, and then we'll start the panel discussion. Thank you all.